I'm Greg Wood. I'm one of the heart failure attendings here, so we'll be covering the CCU as well. So we'll be working with you guys and asked to talk about right heart failure today. I think this is kind of an issue that a lot of people find challenging to manage, and it can be challenging to manage. And so I think getting a sense of how to, first of all, define it, to look into some of the causes for right heart failure, how to evaluate heart failure, particularly at the bedside, with a focus on hemodynamics, and then looking at treatment strategies. And I think that kind of presents one of the most challenging things for right heart failure. So to start with a definition, I think you can think about right heart failure in a couple of different ways. You can look at just purely RV systolic function abnormality, so low RV ejection fraction, often defined by echo or other parameters. And then kind of a further definition of this might be, which I think is more pertinent to the treatment of RV failure, is RV failure in the setting of a decreased cardiac output. And really, like, how do we know if a patient truly has right heart failure, and how do we begin looking at that? So to start with right heart failure etiologies, I think the big thing to take home from this is that the RV, unlike the LV, is very thin structure, is not as muscular, and so is really sensitive to changes in hemodynamics. And I would categorize RV failure into a couple different categories. So something intrinsic to the RV, like ARVC or something intrinsic that causes right heart failure. And then, as I was saying, changes in preload and afterload really can affect that, and some combination of all of that. So some RV dysfunction intrinsic, and then an exacerbation with a change in hemodynamics. So to look a little more at a granular level for etiologies of right heart failure, I think the most common is left heart failure leading to right heart failure. So you get congestion through the pulmonary circuit and leads to right heart failure. And I think it's important to recognize that, because I think, bottom line, in this situation, you treat the left heart failure, and so to kind of recognize that. Other etiologies, so RV ischemia, so any kind of situation, RCA, stenosis, something like that. Even just increased stretch of the RV can lead to RV ischemia. A biventricular cardiomyopathy, a lot of the inherited cardiomyopathies can lead to both chambers being affected. A right-sided predominant cardiomyopathy, ARVC, being kind of one of the prototypic. Valvular disease, including severe TR, MR, or stenoses of the valves, long-standing pulmonary hypertension. And then I think in the ICU, one of the things that we see often is acute changes in preload or afterload. And I think examples of this would be acute lung injury, sepsis, or PE as a good example of a change in hemodynamic conditions. I think also to consider too that as the RV dilates, that you can get new or worsening TR, and then that kind of is a spiral exacerbating, leading to decreased forward flow and ultimately decreased cardiac output. Things to look for on physical exam. I think we all kind of know these pretty well, but edema being predominant right heart failure finding. The jugular venous pressure, and I think this is something that's important as clinicians in dealing with heart failure patients, is to be really good about the examination of the jugular venous pressure. And you can use other tools like an ultrasound to help you in patients that have difficult to find jugular venous pressure. RV heave, TR murmur, hepatomegaly, ascites. And then I think I would add in echo and swan as a component of your physical exam. And I think getting good at bedside echo and interpretation of swan numbers is important in management of these patients. So to start with the echo evaluation, there's a lot of parameters that are used and defined. I'm going to just focus on the first 5 of these because these are the ones that are commonly reported in our echo studies here. The other RV myocardial performance index, strain, and 3D volumes are kind of more in the experimental range. I think strain is kind of coming more and more into favor, but 3D volumes is certainly still somewhat experimental. So we'll look at the septal motion, RV dimensions, TAPSE, and I'll go into what that is, tissue velocities, and then fractional area change. So first, to start with image acquisition, there's multiple views that you can see the RV, the parasternal views, apical forechamber, and the subcostal views. But I think the 2 views, if you could learn any of these views, that is the most helpful at kind of rapid interpretation of what's going on, is the apical forechamber and the subcostal forechamber. So to go into a couple examples here, so this is an example of abnormal septal motion, and normally the LV septum, which is here, if you're not used to looking at echoes, RV is up here and LV is here. And at this particular view, this is a parasternal view. You're at the level of the mitral valve, which you see in the lower image. But there's flattening of the septum, both in systole and diastole in this view. Normally, it should be a donut shape, nice and round. But this suggests that there's pressure and volume overload that is leading to a shift of the septum towards the LV. So it can be a sign of volume and pressure overload. If you just had it in diastole, it's more suggestive of volume overload. So the pressure is includes systole. So another important aspect to look at is the RV dimension in itself. There's qualitative evaluation, and this is somewhat challenging because you have to start with a normal LV really to use these guidelines, because if both chambers are dilated, then it's hard to determine degree of dilation using a qualitative. But normally the RV is smaller than the LV, and the apex is more towards the base of the heart for the RV apex than the LV apex. And as you get progressive dilation, you get increasing RV area, and then a shift of the apex or the RV apex to be more apical rather than basal. Really what we prefer to use is more of a quantitative evaluation, and probably the most useful of these is the apical forechamber basal diameter, and this is an image of that. So this is the apical forechamber view. You have the LV here on the right side of the screen, and then the RV is here. And you do the basal measurement, so right across the tricuspid annulus area. And so normal, again, is 4.2, and in this particular case it was 5.4, so dilated. So this is another parameter looking at RV systolic function called TAPSE, which is an acronym for tricuspid annular plane systolic excursion. So the tricuspid annulus, this is again a apical forechamber. Tricuspid annulus is here. And so what you're looking at is the excursion of that, if you drew a line across the annulus, the excursion of that to the apex. And so what you do is a Doppler measurement of that. And this is a representation of this. So this is looking at the motion of that annulus. So in this view, you have the annulus sits here. And so any movement this way is towards the apex in this view. And so you're looking at the extremes of this. So the furthest basal to the furthest apical. And normal is 1.6 for TAPSE. So if it's decreased, in this case it was 1.2. It suggests kind of decreased excursion of that and decreased systolic function from that. In a similar way, you can look at the velocity of the same area of the heart. And so if the velocity is diminished, then it suggests poor systolic function. Here normal is 10 centimeters per second, and so in this case, when you look at velocities in echo, there's always a baseline, and anything below the baseline is away from the probe, and anything towards it or above it is towards the probe. And so in this case, we're looking at what's towards it because the probe is up here, the annulus is here, systolic movement is towards the probe. And so you're looking at the peak of the velocity, and in this case it was 6 centimeters per second, so diminished below the 10 centimeters per second. So these are kind of the common things when you read an echo report and it says, you know, systolic function is mildly decreased. These are some of the parameters that you look at. This is often not reported because I think it takes more time, and it is kind of is pretty error prone because of the kind of asymmetric dimensions of the RV. But RV fractional area change is something somewhat equivalent to ejection fraction. And so what you look at is the area of the RV in diastole and the area of the RV in systole, and compare those two. And so this is just representing a progression of worsening area fractional change, so 60% on the left to 20% on the right. And here normal is anything more than 35%. So limitations of echo. So I think I've talked about this a little bit. Yeah.
So normal, I'm sorry, can you go back to that one?
Yeah.
So fractional area change is not the EF?
Is not the EF, yeah.
Okay.
Yep. EF is a volume relationship, so you'd have to know the volume in systole and diastole. So this is just area. So limitation, so again, RV is a very complex three-dimensional shape, so it's hard to acquire images of this. And really there isn't a geometric formula. So when we look at the LV, it's, we assume that it's kind of bullet-shaped, and we've developed formulas that account for the volumes and things like that, but you can't do that for the RV. So it makes it challenging. It makes it challenging to acquire images for it. So another imaging technique, MRI. Well, MRI is really good because you can get the full 3D volume, and you can directly measure EF, you can directly measure cardiac output with this. But really this is not a real useful tool if we're talking about an ICU patient that we're dealing with managing acute RV dysfunction or a failure. I think the big disadvantages are availability. You need people who know how to protocol the studies, and that's not available 24 hours a day generally. You need gadolinium, so patients with renal dysfunction aren't able to do the study. There's time, it's a much longer study than just sticking a probe on. Transporting an unstable patient is not always possible. And then I think the other big thing is that a lot of our patients have either ICDs, pacemakers, or swans in, and we can't do MRIs in those patients. And then it's a much more expensive test if we're just looking for, you know, an inflection point in our management. You know, is this patient acutely worsening? Is this, you know, so a quick bedside echo or swan evaluation can help us kind of more immediately without the full study of that. So wanted to move on to swan hemodynamics at this point, and wanted to be a little bit interactive with this at this point. So, so when we're thinking about RV failure, what would you expect to see in right atrial pressures? Yeah, so you think about an increased sort of back pressure because you're not getting that, but really it could be anything. So it could be normal. So if you have a patient who has, you know, impaired systolic function but is pretty well compensated, it might actually be normal, the right atrial pressure. You might see an elevated mean right atrial pressure, as you pointed out, and I think that's kind of the more common when we're looking at, you know, acute treatment of RV failure. And then the other thing to note is that what the SWAN numbers will look like in TR, and this can kind of help you in assessment of the patient and potential management strategies. But here's a normal right atrial tracing, and the waves are defined based off of what's happening in the atrial cycle. And the kind of key when you're trying to decipher which wave is which is to look at the EKG tracing. That's kind of the easiest thing to look at. So if you look at the P wave, that's the initiation of electrical activity in the atria. And so you would expect atrial contraction to happen shortly thereafter. And so that's defined as the A wave. So if you draw a line down below, you have the A wave. Then you have the QRS complex is here. And this is the next waveform, the C wave, is kind of a variable waveform, not always seen. But it's rapid movement of the base of the heart at the start of systole, and kind of movement of the tricuspid valve into the atrium. And so you can see an inflection there, but that's variable. And then you have the Y descent as the base moves away in systole, or the X descent, sorry, I think I said Y descent. And then the V wave is the filling of the right atrium. And then the Y descent is when the tricuspid valve opens and then repeats. So here's a tracing that is in a patient with severe TR, and so I'll walk through that real quick. So if you look, the red line indicates the P wave, and so the wave just after that would be your A wave. And if you notice, there isn't an X descent after here, and you have pretty immediate regurgitation into the atria, and leading to a prominent V wave. So you can see a really tall V wave in comparison to the previous one. And then if you look at the Y descent, you get a really rapid Y descent. You have a lot of volume of blood that moves, and so you have a big pressure change there. So this is something to look for that kind of helps you, if you didn't have an echo, to say, does this patient have severe TR? If you see big V waves and a lack of the X descent and a prominent Y descent, it could suggest there's significant TR in this patient. So if we look at the RV tracing, it's pretty similar to what I said for the RA tracing. It could be quite variable. It could be normal if you're relatively well compensated. And depending on degree of RV failure, you have a variable systolic pressure in the RV, depending on how much force basically that the ventricle can generate. And in general, in decompensated right heart failure, you would expect to see an elevated end-diastolic pressure. PA tracing, again, can be highly variable. In severe right heart failure, you actually start to diminish your PA pressure. So you'll see this picture of a high right atrial pressure and then increasingly low PA pressure. It could be normal if it's an intrinsic problem with the RV and not an afterload problem, or it could be high in the setting of either left heart failure or intrinsic pulmonary hypertension. And then if we look at the pulmonary capillary wedge pressure, again, highly variable, low, normal, high. And you might see the presence of big V waves in this tracing as well. So V waves would suggest regurgitation from the mitral valve. So I think what I would say to sum it up is that you can see highly variable, but depending on the situation, it can guide management. So, and I'll go into that a little bit more here. So one of the key things is looking at vascular resistance, both in the systemic bed and in the pulmonary bed. And so vascular resistance really comes from Ohm's law, which relates a voltage to a current and resistance. If you solve for the resistance, you get a voltage over the current. If we apply that to a vascular system, vascular resistance is equal to the pressure gradient, so the voltage, and then the current is similar to a cardiac output. And so if you look at pulmonary vascular resistance as an example, you have the pressure gradient, so the pressure gradient across the lungs, and the cardiac output. And so we call that the TPG, the transpulmonary gradient. And what that really is the mean PA pressure minus the wedge pressure. So I think it's important to kind of consider this in our treatment. You might have a high PA pressure in a patient, but if you have a high wedge pressure as well, the actual pulmonary vascular resistance might be low. And so you would treat that patient potentially different than somebody who has a really high pulmonary vascular resistance, where the PA pressure is much higher than the wedge pressure. And the same holds true for systemic vascular resistance. So you look at the pressure gradient across the system, and so it's the mean arterial pressure and the mean RA pressure that you're looking at, and again divided by the cardiac output. And I think another useful tool to learn too is the FIC cardiac output. We have the continuous monitors on our swans if somebody has a compatible swan. But often those numbers can be highly variable, and if the quality of the signal is poor, it can't really be that trusted. So I think learning how to calculate a FIC cardiac output can be helpful, both in the management of left and right heart failure. So if you look at the FIC principle, so if you look at oxygen consumption in the body, and it's defined basically as the oxygen content at the arterial side subtracted by the oxygen content at the venous side. And so the difference is how much oxygen you're consuming. And you relate that to the cardiac output. So if we solve for cardiac output in this equation, you're left with this equation where you have the oxygen consumption over the content of oxygen in the arterial system minus the content in the venous system. And if we make some substitutions here, so oxygen content in any system can be approximated by this relationship of hemoglobin to the oxygen saturation. So that's basically giving you oxygen content. And so when you do a quick calculation, the things you want to know are an assumed oxygen consumption. We don't usually measure that. The hemoglobin of the patient, and then the arterial saturation could be a pulse ox saturation, and the venous saturation. And it should be a mixed venous saturation, but you can approximate a saturation off of a PIC line. Really, it should be the PA sat as a mixed venous sat, but if you don't have a swan in, you can use the drawn PIC sat. So if we look at kind of this final equation, how do we estimate VO2 or resting oxygen consumption? And really it relates to body size. These equations, there's a lot, if you look online, there's a lot of different equations that have been attempted, and it's challenging because these equations don't really account for adipose tissue and other things that can vary your resting oxygen consumption. But in general, there's two ways that I've generally used, and one is using body surface area. And so some sources will say 125 times the body surface area, and others will say 135, kind of variable. And then a weight-based, so 3.5 times the weight in kilograms, gives you a rough estimate of oxygen consumption. And obviously a bigger person's going to consume more oxygen. So I think the final thing I want to talk about with hemodynamics is this concept called RV stroke work index. And the reason that this is derived is that it's hard to really get an assessment of performance of the RV just using any of these individual parameters, cardiac output, PA pressures, all the other pressures in the heart. So what RV stroke work index is trying to do is to approximate the work of the RV. So that's basically the pressure that it's able to generate. So if you look at the mean PA pressure compared to the RA pressure, the only thing that affects that is the RV work, the RV force that leads to a higher PA pressure than your RA pressure. And so if the RV can do more work, you would expect that difference to be higher, potentially. And then also a component of this is how much blood is flowing through the heart, so the stroke volume. And to keep apples to apples, you index this to body surface area. So the stroke volume index is just the cardiac index divided by heart rate. And so a normal range is generally much higher than 350, but kind of the low normal is 350. And so if you think about it a little bit, so one of the kind of early, I talked about this a little bit earlier, one of the indicators that you might be having an increasingly failing RV is if the PA pressure is dropping with a kind of same RA pressure. So if you look at this equation, that kind of takes that into account. So if you have a lower PA pressure and hold all the other variables constant, then your stroke work index decreases. And so it's basically the pump is starting to fail. You're not able to mount a bigger pressure in the PA. And similarly, as the stroke volume decreases, if you hold all the others similar, all constant, then your RV stroke work index decreases. So I think to move on to treatment, I think what I would say is, there's a lot of different things that you can treat, and I think using the information that you gather from exam, echo, and SWAN numbers kind of helps guide that. So as I said before, the RV is a very sensitive structure to stretch and volume changes. And so I think the first things to think about is volume optimization. Is the patient dry? Is the patient wet? How should we approach this? Kind of an extreme example of volume optimization, so might be in the case of tamponade, where the issue of poor cardiac output or RV failure is an issue of filling. And so you need to look at the preload in that situation. So bolus might be appropriate in that setting of RV failure. But if the patient's wet and tamponade doesn't exist, then it actually might be diuresis. So you're looking at the patient's volume status. And then kind of moving on to increasing the squeeze of the heart, so inotropy. And I would say, there's really kind of two inotropes, potentially three, but the milrinone, I think, is an interesting inotrope in the setting of RV dysfunction, because you get the inotropic effect, but you also get pulmonary vasodilatory effect. It's a PDE3 inhibitor, and so you get pulmonary vasodilator effect with it. The caveats of milrinone, though, is that you can cause systemic hypotension, so you might be limited by the systemic blood pressures. And also in renal impairment, it's cleared slower and can lead to higher levels, and so you can have a bigger effect in renal dysfunction. So then dobutamine, you get kind of a similar effect. You get inotrope, you get some mild pulmonary vasodilation, and potentially not as much systemic vasodilation, and it's not renally cleared. And then epinephrine, I think doesn't have a huge role in RV dysfunction, and I probably wouldn't really consider epinephrine as a drug for RV dysfunction, because you get vasoconstriction and systemic constriction as well with it. So then kind of looking at afterload, we've talked about preload a little bit here, but RV afterload. I think this comes into play with knowing how to think about pulmonary and systemic vascular resistances, because you might have a problem of RV afterload, but it's really LV dysfunction and the systemic afterload that's the problem, and not so much pulmonary afterload. And so knowing, is the pulmonary vascular resistance high or low, is important in knowing, is this a patient who has a high systemic vascular resistance? Because if it's a systemic problem, you would treat with agents like nitroprusside or lisinopril or something like that to decrease the systemic blood pressure. But if it's a high PVR, then you think about agents that lead to pulmonary vasodilation. So some of those agents, so oxygen therapy is actually a pretty good pulmonary venodilator. So you can get some benefit by just putting oxygen on. As we talked about, milrinone can have some pulmonary vasodilatory effect. And then the PDE5 inhibitors, sildenafil, tadalafil. The kind of downside of sildenafil is that it does cause some potential systemic dilation, and the other effect too is it's a somewhat longer half-life compared to some of the inhaled agents. And then if you look at epoprostenol, also can be a pretty good agent in the acute setting. It's cheaper here than the nitric oxide, but you can use both.
Are you guys doing any NO via nasal cannula?
In general, we don't a lot, no. We do it in the cath lab when we're doing a right heart cath, but we
just to check to see if
to see if they're responders to it, yeah.
what do you find?
It's pretty low number of people that actually do respond.
What group of people do you find usually do?
I don't know that I could say a specific group. These are the pulmonary hypertension, people with true pulmonary hypertension.
Or
But
checking to see if it's true pulmonary hypertension?
well, it's more just to guide therapy a bit for longer term strategies for it. So if somebody's a responder, you might lean towards that. So I think another thing to think about too is in the same way as you're looking at volume stats and things like that. The RV is very sensitive to arrhythmias as well, and we see this a lot in our LVAD patients who have VT. They can do okay for a little while, but then you get this predominant kind of right heart failure appearance to them. And so thinking about arrhythmias, so treating flutter, treating VT or other arrhythmias can help. I think another thing we often overlook is anemia. If you're severely anemic, you could potentially have RV ischemia that's contributing to this, and so transfusing if they're severely anemic. I think it's kind of case-by-case basis a little bit. I mean, if somebody is having significant RV failure and their hemoglobin is 7, or hematocrit of 20 or something like that, then I probably would transfuse. It's sort of true in LV dysfunction as well, to think about. I think another big player here is PE too. We often kind of get so focused on cardiac causes of heart failure that PE should be considered. And I think the other player too here is if the patient's intubated, your mechanical ventilation actually could be hurting you. So high tidal volumes, high PEEP can hurt your RV function. And so maybe adopting different ventilatory strategies to help optimize that. And I think finally, kind of the last resort, if you've tried all of these things, is mechanical support. And there's a couple of percutaneous options that if you're thinking that it's more of a temporary thing to bridge somebody through to recovery. So an Impella RP actually just came on the market, and I think as of this date we haven't used one of these yet here, but we have them available. Here's a picture of it. So it's similar to the Impellas that we use on the left side, the 5.0 CP or 2.5s, but it's been modified. It has a preset curve to it that allows it to be easily passed into the pulmonary artery. but works pretty similar. It's inserted from the femoral vein. In a similar way, there's a new catheter I think came out in the last few years that is used with the tandem heart called a Protect Duo, and we've used this a couple of times. And it's a percutaneous approach again, where you go through the jugular vein. The catheter has an intake in the SVC right atrial area and then output into the PA. And then you hook it to a standard tandem heart externally. Then kind of looking at more longer term approaches and more invasive approaches, so surgical centromag, an RVAD. If there's predominant LV failure, an LVAD might actually be the solution rather than treating the RV. And as you optimize the LV, you could lead to improved RV function. And then ECMO is another support. So I think to kind of summarize here, I think the important things, learning to recognize signs of RV dysfunction. So being good at the physical exam and kind of getting tipped off that maybe this patient is having issues with the RV function. And then I think really learning how to use the ultrasound probe and kind of getting a sense of obtaining those views, getting a little bit of an idea of how to look at the RV function, TAPC, even if you don't formally measure it, but getting the sense of is the annulus moving, and then dilation of the RV. And I think really kind of learning hemodynamics and figuring that out and what to look for and to use that to guide your therapy rather than just kind of a shotgun approach to therapy, looking at each of the individual components. And then I think ultimately keeping mechanical support in your back pocket a bit. And it's kind of exciting to have these temporary devices, less invasive, can bridge somebody through to a recovery rather than a surgical. And just as I can email you guys this, but there's a couple of pretty good review articles that I ran across that kind of help with this. The first one being kind of focused on ICU care. And then the latter two are a series that were published in Circulation that look at really in depth of the RV physiology and kind of management of it. So, yeah. So you guys have questions at all?
So you were saying that you would transfuse for hemoglobin less than 7?
I don't know that I have absolute cutoffs, but yeah.
I mean
that's what I would
the general
certainly.
population is supposed to be transfused. Like less than 22 is the trigger right now per Terry Gernsheimer, I think.
Yeah, so I think the issue is that you run into problems with volume as well, and so I think you have to kind of consider case by case what you would do. But that would be kind of my absolute cutoff. Like, I would really think about it. Then I'd be thinking about it even at like a hemoglobin 8 or 9 in that range too, if you're having significant RV dysfunction.
In your experience, who manages tandem hearts?
So it's the CTICU service that does. Yeah. Pretty much anytime there's a, because I think that's put in by cut down.
Cut down, yeah.
So anytime there's a cut down, generally that's managed by the
Yeah, because
CTICU.
we're not even going to take RPs as the cut down. The Impella RP.
Yeah, yeah.
Does the CCU do ECMO? I've never seen ECMO done in the point where we see it.
The CTICU service does, yeah. Yeah, we do it a few times
CTS.
a year. Yeah, it's generally where I've seen it be successful is the kind of acute young myocarditis patients is kind of the thing that I've seen the most success. Or
For ECLS?
yeah, like in my
More than that, but
yeah, I know there's further, but like in the CARDS B kind of patients, there's a lot of post-surgical issues where people are supported on ECMO and things like that. But the use, where you have fulminant biventricular failure and our patients, I think the thing that comes most to mind is the myocarditis patients. Thanks, guys.
Thank you.
Curious.
We do BB.
Will right heart failure often progress to left-sided eventually, or will usually?
No, generally it doesn't. And I think it's because of the structure of the LV. You don't usually have kind of the reverse.
Okay.
You know, if you,
Because
yeah,
the neuron just basically
it's not as sensitive to the change.
I was gonna ask, how do you sometimes differentiate whether the right side failure is from the left side or from something else?
Sure. I think the things to look at really are, you know, if you have high PA pressures, high wedge pressure, and you know on echo you have a low ejection fraction, LV ejection fraction, then I think it's probably most likely from that. But there might be a component that's driving it. But I would, in those situations, if you have a high wedge, I would sort of treat the wedge first, generally. So you know, supporting the LV, diuresing, afterload reduction systemically.